Good morning, all. I welcome you all from the Department of Orthopedics, AIIMS Bhubaneswar, for this webinar on trochanteric fracture.
Sir, you are not audible.
More? Okay, just let me start once again. Now you're audible?
Yes.
Yes, Subhani, good morning. Good morning, all. I welcome you all from the Department of Orthopedics, AIIMS Bhubaneswar, for this webinar on trochanteric fractures. As you know that trochanteric fractures, in particular old age and porotic bones, there's a debate whether to replace or to osteosynthesize. And for this, we have a panel of experts. From the Department of Orthopedics, we have 7 faculties. Dr. Meghnad Pawar sir, our professor, Dr. Sujit Tripathi, another professor, Dr. Montujan, additional professor, Dr. Gurdeep Das, associate professor, Dr. Gunjar Jain, assistant professor, and our secretary of this webinar, Dr. DEEPAK NERADDI, assistant professor. And we have national faculties. We have our respected Amit Rastogi sir, professor, Department of Orthopedics, BHU Varanasi. Welcome you, sir, for this webinar, and
thank you,
for
sir.
your time.
Happy to be here.
Thank you, sir. Dr. Samarth Mittal is an additional professor from AIIMS New Delhi. He's a pioneer in trauma, and as you know that he works in a trauma center. Dr. Samarth, welcome you to this webinar.
Thank you, sir.
We have Dr. Azad Mohammed. He's also a good friend of our Gunjar, and also becoming the due course of time also became a good friend of mine also. Welcome, Dr. Azad. He's also from AIIMS New Delhi.
Thank you, sir.
We have Dr. Kapil Pawar. He's from Mumbai, LTMMC GH, and he's associate professor. He's a very good trauma surgeon and also plastic surgeon. Welcome you, sir.
Thank you very much.
Dr. Sumanyu Tripathi, he's from KIMS, and you know that he's a surgeon basically known for deformity correction, and he's a good friend of mine. Sumanyu, please welcome to this webinar. Dr. Sikumar, he's from Ganga Hospital, Coimbatore, is a consultant trauma surgeon. And nowadays we'll find very rarely surgeons who express themselves as a trauma surgeon. Mostly they talk of plasticoscopy, spine, ankle. But being a trauma surgeon, I welcome you, Sir Sikumar, sir, and we are eagerly waiting to listen to you and your expertise in the field of trochanter. So without wasting much time, and I also thank the residents, Dr. Guge and other residents who have really taken the pen to organize this webinar. And with that, I welcome the first speaker for today's webinar is Dr. DEEPAK NERADDI. He will speak on how to classify IT fracture with X-rays. So before Dr. DEEPAK NERADDI share his screen, I just like to request everybody that please post your questions in the chat box. Dr. Gunjar, who is the organizing secretary for this webinar, he will take care of your questions, and we'll try to discuss and answer questions as you go in between two subsequent lectures. So over to Dr. DEEPAK NERADDI.
Good morning, everyone.
Dr. Deepak, you can start your presentation.
Okay. So can you see the presentation?
No, we are not able to see.
Hello. Now?
No.
Dr. Gunjar, can you see?
No.
Dr. Deepak, do one thing. You open your presentation in one of the screens. Yeah, now you can see that. Yeah, please.
Okay. So my presentation is on classification of intertrochanteric fractures. So basically, there are various types of classifications for intertrochanteric fractures. So I would like to focus only to, mainly 2 to 3 fracture classifications.
Dr. Deepak, please move to the slideshow mode.
Yes. So basically, if you go to the anatomy of the proximal femur, it is composed of head, neck, and trochanteric area. So if you see the proximal area, there is a capsular attachment from the acetabulum, and it is attached.
The slides are not moving, Dr. Deepak.
Now can you see the
Yeah,
slide?
yeah. Now they are moving.
Yeah, now
Yes.
it's okay.
Okay. So if you see, there is.
You can start the slideshow mode.
Can you see now?
Yes.
Okay. So if you see, there is a tight capsular attachment at the intertrochanteric area. So any fracture outside this capsular attachment is extracapsular, and within the capsule it is intracapsular fracture. So intertrochanteric fractures are basically extracapsular fractures. So it is important to know the muscular attachments to know the fracture reduction patterns. So over the GT, you can see there is a gluteus medius attachment, and at the LT there is iliopsoas tendon attachment. So if any fracture is there at the LT region, it is pulled towards proximally because of iliopsoas, and at the GT, if there is a fracture at the greater trochanter, it is abducted due to the pull of the abductor muscle. Also, you can see posteriorly there is one strong bone from the posteromedial area, that is the calcar area. So this provides the support and prevent the collapse, varus collapse of the intertrochanteric fractures. So all proximal femur is already a high stress zone, and the calcar femoral is very important in the stability of the fracture fixation. So mechanism of injury is basically it is a low energy injury in elderly and high energy injury in young patients. Also osteoporotic
Is it
bones are.
only me who cannot see the slides moving, or
Can you see now?
Gunjar?
The slide is not moving. Dr. Deepak, the slide
is not moving. Yeah.
Now?
Yeah, now you're moving. Now it's moving.
Yeah, now it's moving, but I think you skip. See, go to slideshow
Yes, sir.
and play from start, the leftmost.
Now can you see, sir?
It's
We can
not
see,
playing
but it is
actually.
still not in the slide mode.
Yeah.
Go in the button screen of his laptop, and there is a one play button
Yeah.
there.
Sir, for me it is running in slide mode only.
Okay, fine. Yeah, that one. Play that.
Yeah.
Yes.
I
Switch
think
that button.
I
Click
think
that.
Dr. Deepak, what you can do is just exit the slideshow mode and run from the normal mode. I understand it is a settings problem. It will take a lot of time. So you
Yes,
run
yes.
from the main screen only. Yeah.
Yeah.
Okay.
The screen. Yeah. Every time, yes. Just click here when you are trying to show the slide.
Yes,
Yeah.
yes. Okay, fine. So how do you investigate for a intertrochanteric fractures? So basically we go for AP X-ray, plain AP X-ray of the hip region. Mostly we don't do a lateral X-ray in the emergency setup. Lateral X-ray is useful in the intraoperative setup to see the fracture reduction criteria. So CT, yes, CT is necessary in case of comminuted fractures to see the various fracture fragments. So why is it important to classify the intertrochanteric fractures? It is mainly to identify the fracture pattern, to predict the stability of the fracture, to plan the fixation strategy, and to plan surgical steps, and to predict the prognosis. So evolution of IT femur fracture classification begins from 1949, where Professor Evans started the classification of intertrochanteric fractures. After that, Boyd and Griffin also introduced their classification, and Tronzo in 1974, and Kyle and Gursilo in 1979, and from 1980s to 2018, AO has classified the intertrochanteric fracture classifications. So I will discuss basically on Evans, Boyd and Griffin and AO classifications. So Evans classification is basically on the posterior medial cortex integrity, basically coronal plane stability. So stable fractures are intact posterior medial cortex, and after reduction, if you see the posterior medial cortex is reduced and stable, these are stable fractures. And unstable fractures are posterior medial cortex broken fractures and combination of the lesser trochanter, reverse oblique fractures, and high risk of collapse and varus fractures. So basically, if the fracture is unstable in the coronal plane due to breakage of the posteromedial cortex or combination, those are unstable fractures. So he divided into stable and unstable fractures. Here you can see this, there is a simple fracture line in the stable fractures. It is undisplaced. In the group 2, you can see the fracture is displaced, but still after the reduction, it becomes stable. So again, it is classified into stable fractures. Rest all fractures where it cannot be reduced, or there is any comminution, or there is reverse obliquity, those are treated as unstable fractures according to Evans classifications. Later, Janssen modified them into 5 parts. Type 1 is undisplaced fracture, type 2 is simple displaced fracture, 2-part fracture, type 3 is 3-part fracture, where you can see there is a posterior-lateral comminution at the lateral wall, and type 4 is 3-part fracture again, but there is a posterior-medial comminution, and type 5 is all a 4-part fracture involving lateral and medial comminution. Later, Kulkarni et al. Also modified this Janssen and Evans classification into 3 patterns: stable, unstable, and very unstable types. So, very unstable types are fracture extending into subtrochanteric or fracture extending into femoral neck. Rest all similar to the stable patterns of the Evans and Janssen classification. Boyd and Griffith classification, they considered basically Evans fractures are basically on coronal plane stability, and Boyd and Griffith classification involved the sagittal plane instability. So they included the posterolateral fragment. So type 1 is simple fracture again, and type 2 is comminuted fracture, type 3 is reverse oblique fracture, and type 4 is subtrochanteric extension of the intertrochanteric fractures. So here we can see the first X-ray shows the type 1 simple fracture, second X-ray you can see there is a comminution, and third fracture you can see reverse oblique fractures, and fourth one is subtrochanteric extension. Later AO classified fractures based on the 2-part fracture, comminution, and the reverse trochanteric fractures. So basically AO classification is femur bone number 3, and proximal part it comes to 1, and the trochanteric area is the coding is A, and the neck area is coding is B, and the head area is coding is C. So for trochanteric fractures, the AO coding is 31A. Again, they divided further trochanteric fractures into simple peritrochanteric fractures, that is 31A1, and multifragmentary, those are 31A2, and reverse oblique fractures 31A3. So if you see, so 31A1 is further divided into isolated trochanteric fractures 31A1.1 and 2-part fractures 31A1.2, and involvement of lesser trochanteric fractures, those are 31A1.3. So these are all simple fractures are 31A1, and those 31A1 are further divided into 31A1, 1, 2, 3 based on the number of fractures. So again, multifragmentary fractures are further divided into 2 types: 31A1, 31A2, 2, and 31A2, 3. So in 31A2, 2, you can see there is a 3-part fracture, and there is only one fracture fragment interposed between the proximal and the distal fragment. So you can see there are in the 31A1 simple fractures, the fracture line is approximately more than 20.5 mm from the lateral cortex, which is important for the fracture fixation. In 31A2, you can see the fracture line is less than 20.5 mm from the lateral wall. So 31A2.3, you can see multiple fragments within the proximal and the distal fragments. So 31A2.2, you can see only one fragment, and 31A2.3, you can see multiple fragments between the proximal and the distal fractures. So again, the third fracture 31A3, those are reverse trochanteric fractures. So these are three types: 31A3.1, these simple oblique fractures, and the second type is the transverse fractures, and the third one is the wedge or multifragmentary fractures involvement. So these are the unstable fractures, and these are the simple fractures. So if you classify these fractures according to the AO principles, you can know which implant can be used and how to reduce each fragment. So in 2018, AO further modified 31A1 into 2 types. So simple fracture, but involvement of the greater trochanter or involvement of the lesser trochanter, you can see the coding as 31A1.1N and 31A1.1O. So again, the second type, the simple fracture, two-part fracture, and the third type, you can see involvement the fracture of the lesser trochanter. But in the X-ray, you can see the fracture is displaced, but upon reduction, the fracture is stable. So they involved in 31A1.3. So again, if you see the second type of the multifragmentary type, in first part you can see only there is one fragment interposed between the proximal and the distal fragment. In the second type, you can see multiple fragments interposed between the proximal and the distal fragment. Again, Kyles classified the fractures into four types. Type 1, the stable and undisplaced fracture. Type 2, the stable and displaced fracture. Type 3, unstable fracture, involvement of the greater trochanter and posteromedial comminution. And the type 4, you can see there is a multiple fractures and also involvement of the subtrochanteric area. Again, you can also see Tronzo classified the fractures into 5 types. The type 1, simple fracture. Type 2, displaced fracture. Type 3, posteromedial comminution, you can see. Type 4, along with posteromedial comminution, you can see greater trochanteric fracture. And type 5, you can see reverse obliquity fractures. So further, you can see many classifications like Ramadier's classifications. Again, same involvement of the fractures of simple or the involvement of greater trochanter, less trochanter, or reverse obliquity. And the trochanteric extension. So there are various types of classifications are there. Just we have to see whether there is posteromedial fragments, posterolateral fragment, and the involvement of subtrochanteric area. Further, there is research is going on based on the involvement of the iliofemoral ligament and the reducibility and irreducibility of the intertrochanteric femoral fracture classifications. So these are various types of fracture classification of intertrochanteric area. Thank you.
Thank you, Dr. Deepak, for this elaborate classification of fracture trochanter. So before I would like to one more question. There are so many classifications. Which one
Yes, sir.
really we need to follow?
Sir, like we currently follow AO classification, sir.
But do you think in the clinical practice AO really works?
Yes, sir. So
Okay.
basically, any fracture classification involves the various type of fracture fragments. So what are the important fracture fragments to be reduced? So if you see fracture classification, they mainly concentrated on